And so welcome to this really very first cataract phaco workshop that's run by ISASO. Now, ISASO is the European Society for Advanced Surgical Training in Ophthalmology, which started in Europe, and so far all they've done is basically done on surgical retina, medical retina, uveitis. And so this is the first time that they thought they would expand it into the field of phaco-cataract surgery, and we're very grateful to ISASO for this, and also Alcon, who provided us with an unrestricted educational grant that makes this course possible, and also for the wet lab facilities that we will use tomorrow. You're very lucky people, I tell you why. You're very lucky because when I was a resident or at your level, we never had a course like this. And this course is really very interesting, and I'm looking forward to this weekend because I get the chance to interact with 4 or 5 of my colleagues who are absolutely world leaders in teaching cataract surgery. And it's very rare that you're going to get this opportunity to rub shoulders and really pick the brains of my faculty. So I'm just going to introduce my faculty to you. First of all, at the back there, Dr. Panet Pangkutipong. The Thais among you would know him. He's the medical director of Metaprotera Eye Department and also in the Ministry of Health, very important. But Panet I've known for 20, 30 years, consummate surgeon, wonderful teacher. So I'm looking forward to interacting with Panet. From India, my dear friend Sri Ganesh from Bangalore. Sri is one of the most innovative surgeons, runs a huge private practice, but which does more research than many institutes do, I believe. And you will find that his experience is fantastic. And on his left is Professor Chi Soon Pek from the Singapore National Eye Centre. And Soon Pek is, again, a fantastic surgeon, does the most complex cases and makes them look easy. They're not easy, but she's going to teach you how to do all these things. And right at the back on the left there is Dr. Pham Han Bo from Tan Tock Seng Hospital in Singapore. Han Bo is a member of the implant club, or the power club as they call it. He knows everything about biometry, machines, technology, and so on and so forth, and he will teach us. Now, what all these top cataract surgeons have, apart from their superb skill as surgeons, is they're superb communicators and teachers. So my instruction to them this weekend has been to make this course interesting, exciting, but most of all practical to all of you, and not have too much theory in it that you can read in the books anyway. So we'll make this weekend interactive. Feel free to interrupt any of us if you don't agree with what we say, and you will hear that we often will contradict each other. Professor Chi is always very rude. She always says, "Ron, you're talking rubbish." Fair enough. As long as you can challenge anything we say, and we've got a brilliant faculty here who will also chip in. So with that, let's get cracking. First thing I want to ask is, we need to know how experienced you guys are here. Now, for all of you here, how many of you have done more than 100 phacos? Okay, just a couple of you. So most of you, I would say, have done less than 100. Is that correct? Okay, so now we know where to pitch. We've got lectures from the most basic to the most advanced topics. So what we'll do is we'll start from the basic, we'll go on, and the last day will be really complications and challenging cases. Today we're going to start in the morning with a pre-operative assessment, afternoon we'll talk about surgery, and tomorrow is going to be surgery as well, okay? So I've structured the program to really give you a complete cataract primer and how to set up your practice, etc., etc. So I'm going to start off first with talking about cataract surgery today and really patient flow in the clinic. Now, I have no doubt that cataract surgery is really the best operation in the world. Now, if you want to be a one-trick pony, in other words, be expert in only one operation in any field of surgery, I would think cataract surgery is it. Because no other field of surgery can you have a one-trick pony that you can make a career out of. Okay? It's highly successful, quick, safe, and the patients love it when you give them back their eyesight. What's the volume of cataract surgery globally? If you talk about globally, this is from 2016, you're talking about 20 million. I think now it's probably 25 million, probably, is that right? Globally, is it 25? to 30 million, something like that. So you're talking about a lot. And there's some idea of the distribution of monofocals are still the biggest amount, and torics and multifocals are much less. Now I'm going to start by asking all of you, what sort of cataract practice do you want to have? Now I would suspect that many of you are still in the institution, right, working in an institution somewhere. Now in institutional practice, what's your target? Is just seeing well with glasses after surgery acceptable? Or do you want to do a form of institutional private practice where you aim for better results? Eventually, some of you may go to private practice, but even in private practice, you will find that there are two types of practitioners. One type of practitioner will just do general practice of cataract surgery. And they're happy with the patient wearing glasses afterwards. And if that's what you want, fair enough, you make your choice. But if you want to do better, then you want to do a type of state-of-the-art cataract surgery where you aim for spectacle independence. So the question you need to answer is, are you happy just getting a cataract out, let the patient see 612, use glasses, or do you want to do the best you possibly can for your patient? And I think this is independent of whether you're going to be a private or an institutional cataract surgeon. Philosophically, you need to decide where you want to be. And if you want to be the latter, I think this course is for you. Now, let's talk a little bit about setting up your clinic. Because your cataract patients, your surgery starts from the moment the patient walks into your clinic. You need all these things, equipment, staff, very important, patient flow, etc. This is my clinic room in my private practice. It's like any clinic room. You see my slit lamp is there, but the difference I will have is I was telling you that I have a television monitor connected to my slit lamp. My patient's relatives sit there, and the patient obviously sits there. And I'll tell you why this is important in a minute. The essential equipment you obviously need: slit lamp, ideally with a camera, as I pointed out. You need a biometer, you need autokeratometer, pentacats are optional, you need a topographer. I think increasingly nowadays, I think Sri, you're going to talk to us about topography and whether it's important for the cataract surgeon, and I think that you might need an OCT these days. So here's one question. When you're doing a cataract workup, should we do a routine OCT as part of a pre-op assessment? In the US, they don't, because the surgeon doesn't get paid for it. The rest of the world, in Asia, we tend to do it because we think it's important. And this is a paper that just came out in this month's JCRS. The prevalence of macular abnormalities identified only by OCT. In other words, when the surgeon looks at the patient's macula, it looked normal. They would have missed 7% of macular pathology in that case. And if you're putting in a toric lens, if you're putting in a multifocal lens, you're going to look very silly when the patient cannot see because of a macular lesion. So I would encourage all of you, if you can at all, do a routine OCT as part of your pre-op assessment. Now, one of the challenges is, when you're in a clinic and you're busy. Now, all of us run different clinics. I'm sure Sri and Pandit, when you run a clinic, you see 30, 40, 50 patients in a clinic. That's very challenging. My private clinic, I see 10 patients, 15 patients, totally different. But the challenge is, how do you identify cataract patients when they walk through the door in your clinic? Because you need to know that before you can direct them to the investigations. Now, if we're talking really about the new patients, now how many of them actually refer to the diagnosis of cataract? Maybe not so many. You see, typically a GP who refers a patient, say, doctor, this patient has blurred vision. But when the patient comes to you, you don't know what he's got. Can your staff triage and check how many of them are cataracts? Maybe. But I think the best way is for all your patients to come in with blurred vision. I would like to see them very briefly first at my slit lamp, just to see if it's a cataract problem, because then I can send them out for all the tests that they need. And what you do is I just put them down and say, hello, what's the problem? Bit of blurred vision, very short history. They'll have a quick look at them, and you can see through the pupil whether they have some cataract. Is it likely to be a cataract problem? If it is, I send them one direction. If it's not, I send them in a different direction. So at my initial contact with the patient, I take a brief history, I look at the lens, I look at the ocular surface, and again, Sri is going to talk to us about the importance of optimizing the ocular surface. Now, if it's cataract related, they get sent straight for biometry, keratometry, and topography before dilation, right? You don't go and send the patient up to dilate and then check to see if they have cataract or not, and then your biometry is going to be inaccurate. So once they've done all these things, then they get dilation, fundus photo, OCT. But if it's not a cataract, I see no cataract at all, then they need refraction, visual fields, etc., etc. We're investigating them down a different track. Now, I mentioned earlier the importance of this piece of equipment, the photo slit lamp. Now, when any of you set up your private practice in future, I guarantee you this will be the best investment you make. Maybe 50% more than a slit lamp, but if you have a photo slit lamp, it's so good because as you can see here, whatever I see down here, I can shoot it up there. And the patient is actually sitting here, and I can point out that, look, you've got a cataract there, or you don't have a cataract, and the patient's relatives are typically sitting over here. They can see me examining the patient, and they can see what I am seeing up there, okay, and I can explain to them. So, you see, through the undilated pupil, you already get a very good idea whether the patient's a mild cataract, moderate cataract, advanced cataract, or a white cataract. You can make some decisions already based on that. And what's very nice about having a photo slit lamp in your clinic is that after surgery, this is the day after one of the typical phaco's, the patient looks, I say, okay, this is your eye now, you're looking very good, and this is what your eye looked like before, or this is what your other eye looks like, and that convinces them immediately they should go ahead with the second eye operation. You know how some patients don't like to do the second eye so quickly? Because you look at the difference between your right eye and your left eye, and they're convinced immediately. So the photo slit lamp is really very, very useful if you're going to be a cataract surgeon. I mentioned this earlier, but I will repeat it. Do your keratometry and all these investigations, aberrometry, before dilation, and optimize the tear film first if necessary. So at second contact with the patient, that means they've gone up, they've done all the tests, and they come back with all the data, and they come back dilated. I will look at the cataract, I will look at the fundus, I will look at these investigations, and then I will discuss choice of IOL and procedure with the patient. We then counsel them as to which type of IOL, and Dr. Pham later on today, I think, is going to talk to us about IOL choices. Now, if the patient knows, sometimes patients come here and know, I want the same lens as my sister or my friend, and they've had a trifocal, panoptics or whatever. That's easy. But sometimes they say, I'm not sure, I've heard this and I've heard that. Then never pressurize them, ask them to go home, think about them. Give them the brochures, and then come back to me when you're ready or you want to discuss some more. Now, I ask this question because I teach residents in the National Eye Center, and they'll come up to me and we're about to start operating, and I say, what's the density of this nucleus? And they look at me and they have no idea. You know how? I said, because it's very important. You're going to change your technique depending on the density of the nucleus. So the first thing I look at when I look at a set of notes, be it my own, which I know I will have written, but more importantly, if somebody else has listed the case for training, is how dense the nucleus is. Because if it's very hard, we'll do a chop, direct chop, or a femtosecond. If it's soft, we will need to change it. I think Dr. Panett is going to talk to us about soft cataracts later on. I like to know whether the pupil dilates well. Because if the pupil doesn't dilate, I can't do a femtosecond laser procedure. Right? And so I like to see the patient before dilation and after dilation, ideally. You want to know how deep the chamber is. You want to know, is the lens shaky? And then I would often write down in the notes, this is for a flax, or this is for a pre-chop, or this is for a standard stop and chop. And then I will choose the IOL. You all do that. And if I'm not putting a multifocal, I will write down, am I going to do monovision? Which is the dominant eye? And which eye am I going to undercorrect? Now, so this is where the patient comes back in with a dilated pupil. You can see the type of cataract they have, and again, no cataract, mild, moderate, and severe cataract. And this is the data I put into the notes. Now, who does your IOL calculations? Now, some of you may be lucky enough, you have a technician in your hospital to do it for you. And certainly, I think you've got 50 to 100 patients in a day, you're not going to be able to do them all. Then you need to train your technician to do it. Because my load is not that heavy in my private clinic, I do all my own IOL calculations. At the end of the day, I do not allow my staff to disturb me with signing checks or paying things. Beware of all these things and check. Again, we have 3 sets of checks. I check, my nurse checks, and my listing staff checks, so that you don't get any errors in the OR. Always plan for both eyes to do surgery. and always do biometry to both eyes, because that helps you check each other. Now, I often do my cases 2 days apart, sometimes a week apart, rarely a month apart. But if the patient is happy after one eye is done, we can always wait. What about bilateral simultaneous surgery? We can discuss that later on over lunch. Okay. So finally, you bring all this data. Remember, you've done all this data. You've got to get this data to the OR. Sometimes it's through the cloud, and sometimes it's through a thumb drive. And with that, you're really set to go. All right. So that's a very brief summary of what I do when my patient first walks into the clinic. All right. Thanks very much. And I'm going to pass you on to the next speaker, who is going to be Professor Chi. And she's going to tell us about how to assess a cataract properly. Thank you. If you have any questions while Professor Chi